issues victims of COVID-19 are having are respiratory ones. So we're going to break it down with two leading doctors. Dr. Roger Svelte, a pulmonologist, and Dr. Jonathan Baugh, an emergency room physician, are joining us now to tell us what's happening. Doctors, thank you very much for joining us.
Thank you.
Thanks, Sean. It's Lindsay.
All right, doctors, there is a video going around that's getting a lot of attention by a Dr. Cameron Kyle Seidel. He is an ER doctor in New York City, and I want to play you what he says is happening in New York City.
COVID-19 lung disease, as far as I can see, is not a pneumonia and should not be treated as one. Rather, it appears as if some kind of viral induced disease, most resembling high-altitude sickness. It is as if tens of thousands of my fellow New Yorkers are on a plane at 30,000 feet and the cabin pressure is slowly being let out. These patients are slowly being starved of oxygen. I don't know the final answer of this disease, but I'm quite sure that a ventilator is not it. That is not to say that we don't need ventilators.
Now that video has already gotten over 600,000 views on YouTube and caused a lot of concern, obviously. Now, let me preface this by my entire medical training comes from watching ER, so I'm going to defer to you guys on this. But from what I understand, and he goes on in the video to explain that most of what comes into emergency rooms is being a virus-caused pneumonia is what we're treating for. And most of these patients are being treated for what they call acute respiratory distress syndrome. What that means, and you guys can tell me if I'm wrong, is that they're put on a ventilator, and then in many cases, the ventilator is causing more problems for the lungs than they had before. So, Dr. Svelte, I want to start with you. As a pulmonologist, is this doctor correct that these ventilators are, in some cases, causing more harm than good?
Yeah, I think he's maybe overstating the case a little bit. It's becoming more and more apparent that COVID-19 is like an elephant in a very dark room, and we've got a bunch of people in there trying to figure out what this is. And some people are feeling the legs, and another person is feeling the trunk, and they're all correct, but it may be presenting in very different ways. I've taken care of some COVID patients in our hospital, and of course, I'm a critical care doctor, so I take care of the ones in the intensive care unit. And the ones that end up there are the ones with very wet, soggy lungs that ventilators do a very good job of ventilating and opening up their lungs. But there's no question, there's some research coming out recently, Dr. Gattinoni out of Italy, who's saying there may be two different types of lung injury in these patients, and ventilators may not be the fix-all for all of this.
Dr. Baugh?
Yeah, no, I agree with that. And that the article by Dr. Gattinoni really talks about maybe we need to look at the individual patients instead of just going by protocols, whether we're using mechanical ventilation or a non-invasive ventilation. We know that for some patients, without a doubt, we need mechanical ventilation. We need to put them on a ventilator. Dr. Svelte and I see sort of the two different spectrums of patients, or the two different ends. I see the patients who come into the ER, and some of those patients need immediate ventilation. They need intubation right away, and some of those don't. And we are being taught right now, and the sort of the standard right now is to be able to provide early ventilation. We might have to continue to look at that and rethink that, because what we really know is we don't know everything yet. We're in the process of learning about a new disease that's a novel virus and is bringing to us a new disease that we really know very little about.
You know, as we learn about this, obviously people are trying to figure out how can we find a solve. Hydroxychloroquine, a drug that has gotten a lot of attention, and I know that it's starting to go into clinical trials right now. But another drug that has come out is ivermectin, an anti-parasite drug. It's shown that maybe even in 48 hours that it could be curing the coronavirus. Can you guys confirm if this is looking promising or not, or give any insight into ivermectin?
Yeah, very good, Lindsay. That's a very good question. The data that we're looking at is in the test tube. So we take cells and we see if the ivermectin in the cells can actually shut down the virus. And what it showed was that, you're absolutely right, after 24 to 48 hours, there was a 5,000-fold reduction in the amount of virus, not only outside the cells, but also inside the cells. But I can tell you of many studies that scientists have done over the decades that looked great in the test tube, but just did not play out in real life.
Dr. Baugh?
Yeah, no, and that's the key. I think one of the things that we all need to remember here is the fact that this is going to take some time to be able to play out, whether it's hydroxychloroquine or it's ivermectin or whether it is convalescent plasma. We can have good studies or we can have good test tubes or we can have lab examples, but until we have success with patients, we're not going to know those answers. And so it's going to take a little bit of time. I do agree with the fact that we need to keep trying in this process.
You know, we've been focused a lot in the country on the people who have COVID-19, or actually that are getting treatment, rather. What we're finding, or at least hearing, is that there's a lot of people who are asymptomatic. There are people that actually have COVID-19, but don't have the fever and the other symptoms that normally would be what would take someone to the emergency room. So let me read you what the head of the CDC said about what's going on now with people who have. He said, Dr. Robert Redfield says, one of the pieces of information that we have pretty much confirmed now is that a significant number of individuals that are infected actually remain asymptomatic. That may be as many as 25%. That's important because you know you have individuals that may not have any symptoms that can contribute to transmission, and we have learned that, in fact, they do contribute to transmission. Dr. Fauci, who we see every day out there telling us what we should do and shouldn't do, this is what he had to say. Let me play it for you.
It's very important to appreciate and to understand how much that virus has penetrated the society, because it's very likely that there are a large number of people out there that have been infected, have been asymptomatic, and did not know they were infected. If their antibody test is positive, one can formulate kind of strategies about whether or not they would be at risk or vulnerable to getting reinfected.
Dr. Baugh, let me ask you, how important is it that we develop this antibody test so people know whether or not they don't have to worry about it?
Well, I'll answer it in this way, too, saying that if there's a way for us to get back to normal society and reopen America again, this is probably the way that we get to that. Because as we test the antibodies, the IgG and the IgM, we can determine whether or not somebody has already been infected with COVID-19 and whether they're going to be transmitting that to other individuals. So to be able to develop that IgG, IgM antibody test is very important for us to be able to get a grasp of how deeply it's been penetrated into our society already.
So let me just clear this up for a second. Let's say the test comes out, and I get your point. Once you know how many people have it and don't, it makes society a lot easier to open back up. But if you take this test and you test positive, meaning that you've somehow had it, does that mean that then you are immune from getting it again?
So we know that once we have a virus, we do gain an immunity from it. What we don't know yet is how long that immunity lasts. As we gain those antibodies in our system, they do serve a protective factor for us, but we don't know how long that lasts yet. With many viruses, it lasts between 9 and 18 months. And so we don't know yet. But yes, the answer is it should serve as some protection against it.
You know, Dr. Swell, as a pulmonologist, I know some people are concerned that when they contract COVID-19, the long-term lung damage that it may be caused because of this. Is there concern for people that are asymptomatic that there actually might be concern for there to have lung damage as well at all?
No, it's pretty low likelihood. Patients that typically end up with lung damage are the ones that are going to be on the ventilator. They're going to be having pneumonia, and when that pneumonia resolves itself, it might leave a bit scarring. It might leave the lungs a little bit deconditioned, but your lungs, as it turns out, are very over-engineered, and you can actually do quite well on the lungs that you have. And so I think the chances of that are pretty minimal.
Gentlemen, I want to thank you for what you're doing on the front lines to fight this and to help people get through it, but also for so many people in our audience, clearing up so many of these things that are out there about what people should and shouldn't be doing. It's super helpful what you've done today. Thank you very much for joining us.
Thank you.
Thank you, Sean. Lindsay, thank you.
You bet. All right, here's a question.